Thank you. So, welcome everybody to SFS, your global surgical network. If you have not downloaded the app, please do so on the App Store and on the Play Store. And you can install the app and become a member. You can also follow us on social media, on X, LinkedIn, on Instagram, and Facebook. So, please find SFS on these handles and follow us. It's a great pleasure for me today to welcome Professor Milsom, who you can see on your screens. Professor Milsom is also joining us from New York. So it is early morning, 8 a.m. On Saturday. So I'd like to thank him for joining us. A little bit about Professor Milsom. It's a great privilege to actually welcome him. He's a true pioneer in modern surgery. He's internationally recognized as one of the leaders who helped define an advanced, minimally invasive colorectal surgery. At a time when laparoscopic colon surgery was still being questioned in the 1990s, he was among the early innovators who not only adopted, but he also helped shape and validate the approach, fundamentally changing how today we operate. What makes Professor Milsom truly unique is that he has never been satisfied with the status quo. Throughout his career, he has consistently looked beyond the current horizon and pushed the boundaries of where surgery can be. Today, as we stand in the era of robotic surgery, Professor Milsom is once again at the forefront, exploring the intersection of GI surgery, radiology, and novel techniques or technologies to redefine what minimally invasive really means. He's going to challenge us to think differently, not only about tools, but about the very philosophy of surgical intervention. So it's incredibly fitting that he joins us on SFS today and is going to speak on Beyond Robotic Surgery, the Future of Surgery. Professor Milsom, it's an honor to have you with us today.
Thank you very much. And good day, everyone, ladies and gentlemen, and members of Society for Surgeons and other organizations who may join. I'm really very honored and feel very fortunate to, number one, be a colleague of Dr. Shukla's and be involved in SFS, and likewise to be able to share some ideas with you over the next 20 minutes. And then hopefully we can have a lively discussion afterwards. And so should I start sharing slides?
Yes, I just had one or two questions before you start. Um,
Sure.
like we were at the era of laparoscopic surgery, and now we are in the era of robotic surgery. Is this an inflection point in your mind? Do you think, are we missing something here as we embrace robotic surgery with lots of enthusiasm?
Well, that's implied by the title, of course, but of the talk.
Yeah.
Uh, the answer is yes, and I think it'll be evident in my talk where I think the direction of GI surgery will be going.
And as we get surrounded by so much technology, and this is a question which is relevant for our surgical trainees and younger surgeons, how do you ensure, with all the development you're doing, that surgical judgment remains central and we don't become dependent on these tools more than we should be?
Look, it's a question of sticking to the basics, okay? The basics being go understand the problem, talk to the patient. Don't over rely on the technology and tools, remembering that what you possess here will remain among the most important and fundamental tools that you have, that and this, notwithstanding the tremendous abilities we have to go inside the body, to use artificial intelligence, to use new 21st century technological advancements. Nonetheless, the foundation will rest on what's all of us possess right inside our bodies. And surgery, of course, is going to be one of the last domains that could potentially be, quote unquote, replaced by 21st century type tools.
Thank you. Okay, please go ahead with your presentation. You can share, and I will be muting
Okay.
myself and my camera will be off, but over to you.
Thank you again, Dr. Shukla, and I'll go to the presentation mode here. So you'll notice that even with my with my title here that I'm part of a group of clinicians at our hospital here in New York, Weill Cornell Medicine, that involves not just surgery but radiology and population health. Population health being intricately interwoven with data science. Okay. I don't need to tell people on this talk that things like cancer cases, an aging population, and over on the right side, the increasing costs of healthcare, in particular in our country, who's the world's outlier, are serious crises that we face when we start thinking about what are the new things that we need to do in the surgical care of GI patients. This is just one of the recent papers that bears tribute to the tremendous burden that GI patients present to the healthcare system in the United States. These giant numbers don't reflect the GLP-1 explosion that's also going to affect GI care in many, many ways. And no one needs to be reminded about this unfortunate phenomenon that's being experienced worldwide, which is that colorectal cancer in the young has now become, in the next year or two, the leading cause of cancer-related mortality in young patients. So let me start our thought journey off by saying when I saw that cardiologists and interventionalists could replace the aortic valve through a few punctures in the groin, I knew that a journey that we were on needed to be realigned somewhat. And likewise, none of us need to be reminded about what is happening in vascular surgery. This is one of my colleagues who I thought was going to join us, Dr. Ivanchev. This is one of his colleagues in Germany doing an interventional vascular procedure using advanced forms of imaging. And you can see what's happening on the right side of the screen, that most, if not all, of the aorta in this patient is being replaced. And then this is just kind of a summary of one of Dr. Akrasi Ivanchev, who's one of my colleagues, an interventional radiologist who spent most of his career in vascular surgery. But this is one of his patients, and you can see endoluminally, using image guidance, the entire aorta and down to the iliac vessels has been relined using endoluminal techniques. And so I want to just throw it out there today, everybody, and think about this. Most GI surgery concepts today, including robotic surgery, to my mind, have more to do with ideas conceived in the late 19th and early 20th century than they do with the 21st century. Robotic surgery, you could say, is just another way, a fancy way, to chop out the intestine and put it back together. Just a second. And so as we go forward, what should we be focusing on? Okay, that's what I'm going to talk about over the next few minutes. And these are some of the things that we've learned from some of our other surgical disciplines. Vascular is one. There are others like spine, orthopedics, and neurosurgery. Doing procedures that formerly required many days of hospitalization, now as an outpatient with fewer incisions. And for us in GI, we need to start thinking about non-resectional approaches to treating diseases, including cancer. And how are we going to do that? Well, in my mind, it's going to be through these, these sorts of methods, more advanced forms of imaging, better use of data and artificial intelligence, and new tools. And so how are we doing that? How are we looking inside the body? Well, people have been doing this for decades. Some of you might know these doctors, Doctors Bersi and Nejat. They're using fiber optics now to try to look this in this case in somebody's throat, but they're trying to see inside the body better. That's an imaging tool that doctors in the 1970s, this is the best they had. Some of you may know this name, Kurt Sem from Germany. Look at what he's doing. He's hanging a, a ring off of something he's attached to his head, so he frees up a hand, so he can look inside the body more efficiently with a Hopkins rod lens system. He's trying to see better. He's trying to use, if you want to call it, an advanced form of imaging, the best that he had at the time. So, what, to my mind, was one of the most valuable lessons that surgeons learned in the 1990s? We started realizing we didn't have to directly view our diseases in order to look at screens. Sorry, in order to treat patients. Hold on one second. I'm taking care of my granddaughter, so hold on one second. Ruby, you got to do it yourself. Yes, you can. So the standard surgical workflow, think about this now. In this era, we have a patient who's sick. They get an imaging test. It goes on to a hospital electronic record. We look at it somewhere in our office, maybe even in the OR at the nurse's computer or a computer that we have on the side, but we do the procedure from memory. That oftentimes the advanced imaging that we got prior to the operation was not available directly when we were doing the procedure. This is a culture. This is our workflow that we currently have. Okay, so I'm going to talk a little bit about what image guidance is. And it's not, and it doesn't have to be overly complex. It's imaging in any form that we use to improve outcomes. And again, it's widely used in other specialties every day in the midst of the operation. The specialties I mentioned to you already. And we have one advantage that many of these other specialists don't have. We can directly view the disease often endoluminally with a scope, in addition to treating the patient in the fashions in which we've defined. So, for example, here's a use of image guidance that we can use with pre-op imaging. Somebody needs a stoma. They're desperately ill. They're obstructed, like you see in this image here. We can take the CT scan. We can measure with a caliper on the PAC system, on the imaging system, and know that 7 centimeters to the right of this divot from a previous incision the patient had, we're going to find this dilated loop of bowel. Okay? This is image guidance. It's something actually we don't use often enough, that you can take simple images and translate them into action in the OR with this sort of a process. Likewise, I find that GI surgeons do not use routine fluoroscopy that's available everywhere. In fact, again, these mobile units are used probably in every hospital, represented by every person in this call. And this is for use for fractures. It's used in the emergency room. These sort of very portable units are available, but we don't use them often enough. I want to talk about some of the accidental innovation that I achieved a couple of years ago in a patient with a bowel obstruction where I happened to have fluoroscopy in the room. What I'm just going to show you quickly is that this patient had a bowel obstruction. The surgeon who consulted me asked me to scope the patient because they thought the patient might have had an anastomotic narrowing that I could dilate. But what I encountered upstream of ileocolic anastomosis was this kink that you see right here. And what happened was, in the process of trying to put a guide wire through that, and again, I had fluoroscopy almost by chance at this point, I was able to pass the scope through, and you can see that the direction of the bowel changed. In other words, what I discovered was that I actually broke an adhesion. I was able to change the course of the gut, and the patient recovered quickly, no surgery needed, using image guidance and endoscopy, and her obstruction was opened. And this is what this looks like. And we've gone on now to treat dozens of patients now using image guidance, which can include endoscopy. In a patient, this is a patient with a small bowel obstruction that we were able to approach endoscopically. And you can see we've gone through the kink, the obstruction, and you see a dilated loop of intestine like this. We're able to, in many cases, in most cases, dilate this up, break the adhesion, and the patient gets better without any surgery. But this is a byproduct of using advanced imaging. Okay? And the technique is something along this line. This is something we're showing in the lab where there's the adhesion in the intestine and using balloon dilation, and in this case, a vascular type balloon that's used in the aorta and the iliacs, we're able to break open that obstruction. And it's not unlike what you see in vascular dilations, where the adhesion can be broken and opened. Okay? Likewise, we use fluoroscopy when we're creating a stoma. You can see here, air is insufflated, carbon dioxide air through the colon. We're marking it with a scissor here, and you can see where a colon is. This is in a patient with a hostile abdomen, where it's not so simple to just quote unquote do laparoscopy or quote unquote do a laparotomy even. It's much more precise and safe to take the patient like this, insufflate and use fluoroscopy in the time of surgery, and you can see where the colon is and just cut down on that area and bring it up to the skin. There are better examples of this. This is a patient who had a very hostile abdomen, actually had a free flap overlying the intestine, overlying the abdominal wall, and there's a kink right here where you see the arrow. And what we were able to do with this patient, again, using image guidance, is open this up endoscopically. Now, what we did in this case, which is getting a little more fancy, is we were able to make a 3D reconstruction of the upper GI tract based on that CT scan. This is using standard vascular software. This happens to be a GI system, a GE General Electric system, but we were able to see where the kink was exactly. We were able to superimpose this image from the left onto the patient's body using fluoroscopy in a standard, what we would call hybrid vascular room. And using that, we were able to pass an endoscope through the patient's mouth, open up this obstruction, and the patient went home in less than 24 hours with a complete recovery. We're also looking at the possibility of taking a percutaneous approach, a direct path through the abdominal wall using image guidance into the intestine. And we're using this for the sake of time. I'm not going into all the details, but we've done this in about 40 some patients with a technical success of about 95% in opening up small bowel adhesive obstructions without any major complications. We have had a few patients who have recurred, but the interesting thing is that most of those patients we've been able to treat with just a repeat procedure. This isn't like quote unquote regular surgery where the patient has to have incisions and a laparotomy or laparoscopy, but a repeat procedure. And in most all of those patients, we were able to treat them again with the same method. This is the dramatic difference that you see. And a catchphrase that one of my patients coined, oh, this is needles, not knives. And that's where I think one of the big directions of GI surgery is going in the future. This is another thing that we're doing. It's called image guidance using augmented reality. You see one of our former fellows here wearing a Microsoft HoloLens where he's seeing the image that you see over on the right side of the patient on the abdomen, where we're able to make a mark, know exactly where the colon is, and just cut down to that area. No laparoscopy needed. Cut down to that area, bring the colon up to the skin. So the images that he was seeing are something like this now. We can take the patient's CT scan. make a hologram of that, and then co-register that on the patient's body, like so. And what you're seeing here is two guides. This is a patient with a bowel obstruction, where we're going to get percutaneous access to the patient through those little green rods you're seeing after co-registering this patient's CT scan hologram onto the patient's body, which then allows us to know exactly where this dilated loop is. One of the percutaneous access devices, I mentioned my colleague, Dr. Krasy Ivanchev. Dr. Ivanchev and I and others are developing is a percutaneous access tool. That's called the Nicky device. It's like a laparoscopic trocar. You can see it on the right side of here. And again, it's an image guidance tool to avoid opening body cavities. I'm going to show a brief video. I'm just going to show you the highlights of how the Nicky works, but you gain access to the abdominal cavity. In this case, again, a bowel obstruction. With Nicky. You get access. In this case, we're showing its use with using pneumoperitoneum and a laparoscopy. But what we do using image guidance, we target the dilated loop of bowel after getting the device into the abdomen. The device then can suction itself onto the bowel wall. It actually clamps itself like so, grips the bowel wall, and then using vascular type techniques with guide wires and catheters, gain access to the intestine. We're using fluoroscopy, as you see, and then we can actually pass a small endoscope. In this case, a 3 to 3.5 millimeter endoscope inside along with the guide wire. Use that to open up the obstruction. Okay, and then the Nicky device then has a closure device on it that allows you to safely close the intestine and exit the abdomen. So these are some of the ideas that I'm working on. I just want to kind of summarize in keeping in the spirit of this talk that say that most things we're doing, and we've got to stop endlessly refining how to chop out the intestine. That, and again, being severely critical, that's what robotic surgery in its current form is doing. It's another fancy way to chop out the guts. We need to align ourselves to build a new medical culture that's image-based, that's going to allow us to start using images in all of their forms more elaborately in the operating room. Okay, this is one of the image fusion tools we're doing with a company, working with a company called MetaView, where we can fuse the CT generated hologram onto a patient. In this case, this is a lab experiment showing how we can target the appendix and very precisely place tools, and then go on to actually, if you want to call it ultra, we are calling it ultra minimally invasive surgery, placing a small camera in there so that we can actually see the diseased area with several small tools that are placed through needle punctures, and that we can very precisely carry out surgical actions like what I'm showing you here. And then do these types of things where we envision things like appendectomy may be able to be done under local, potentially in the doctor's office. Yes, that's what I said. So I'm going to just summarize to say, in the 21st century, as we move forward in GI, we need to think about converting more patient care from inpatient to outpatient, making fewer incisions, thinking about needles, not knives, and thinking about non-resectional approaches, which I haven't gone into that much today, for certain things, including cancers. And if we do that, it's going to be accomplished through the things that I've mentioned: imaging methods, through better data processing, use of artificial intelligence. We didn't talk about in detail, but some of the imaging and image generation tools we're using are relying on this. And then I talked about new tools and devices that we are now working on, very analogous to what happened in vascular surgery over the last 10 to 20 years. And with that, I will stop.
Thank you. Thank you, Professor Milsom. That was very
Quick run through.
inspirational, very innovative. I think I'll get started with some questions, and if anybody in the audience has questions, please put them into the Q&A. We'll take them as you put the questions in. So what we can see is that your work is being focused on the intersection of surgery and interventional radiology. That means you're working very closely with your radiologists. So how do you envision this convergence actually working in various departments across the world? How do surgeons converge with their radiologists? And obviously, you have learned all these techniques of doing percutaneous access, etc. So how do you envision this challenge? What's going to happen for surgeons to get trained in what you're creating?
Okay, older doctors like myself, right? Some of them are going to feel uneasy, let's say. On the other side, I just was at a training course a few weeks ago with graduating colorectal surgery fellows from the United States, okay? Where we went through some of these exercises using the Nicky device, etc. Most US surgical trainees, by the time they graduate from their surgical training, they've had plenty of hands-on with guide wires, catheters, and balloons. Okay, they feel very comfortable with this. Okay, I think the other thing is that we need to take a lesson from vascular surgery. And you could say we need to take a lesson from cardiac surgery because remember in the 1970s and 80s, some of you may remember, cardiac surgeons didn't take that lesson. And so as a result, a lot of their practice was wiped out. Cardiac surgery downsized, okay, as a result. And so, look, change is inevitable. In the 21st century, we are not going to keep endlessly refining how we chop out the intestine. We we're all well aware of the fact that various forms of chemo, immuno, and radiotherapy are eliminating GI cancers. Okay? A direct approach to those diseases using some of these very same tools. I'll give you an example. We're interested now in non-thermal ablation. Most surgeons on this call are very familiar with the fact that for smaller primary solid tumors, ablation is equivalent to resection. There's no reason that same sort of mentality cannot be applied to the GI tract, especially if non-thermal or other local forms of therapy are found to be effective.
Thank you. We have a question from Dr. Rishi S. I'm not sure where he's joining us from, but he asks, how controlled is the balloon dilation? What French? Up to what diameter do you normally distend your balloon?
Yes, that's an interesting question. The answer is we're using, judgment, but it's probably going to be somewhere between 12 and 20 millimeters. And look, you're getting yourself out of a situation where the patient probably is not a good candidate for laparoscopy or laparotomy, where we might have a shot at using this technique, and so you have to use your judgment. But the other thing to remember, but like I said, you don't have to dilate it up to the normal diameter of the bowel, right? You just need to get the patient extricated from this obstructive episode. But it's in a range between, let's say, to put a number on it, between 12 and I've never dilated anything larger than 20 millimeters.
He has a follow-up question on the post-op adhesions for the small bowel obstruction. Question is approaching the bowel percutaneously using a device like the Nicky device. Are you worried that you might hit those adhesions and cause further damage? And how do you tackle that? I guess that's where real-time imaging may be helpful, right?
Sure. Look, at the present time, using a technique like percutaneous approach, all of these patients are, you're a surgeon, all of these patients are consented for, I'm going to try the percutaneous access. If that doesn't work, I'm going to potentially have to do a laparotomy, okay, right now. But if we can avoid those situations, and everybody on this call, I would guess, has the patient where it's not a favorable situation for laparotomy, whether it's multiple previous operations, inflammation, it's an early post-op patient. Um, so there's a judgment call, but we have the patients, remember, also. And so small bowel obstruction, an extremely common problem that everybody's familiar with. There are, and of course, right now there are variations. There are patients where you can't do this. The obstruction is not amenable to a percutaneous. That's a subject of a whole separate seminar someday, maybe, Dr. Shukla.
Yes. We have a question from Dr. VK, who is asking about the appendectomy you were, alluding to. Do you think that those could be also someday being done in an emergency setting? And in case there was a perforation, would that be something would also you think coming in the future?
I do. I do. And I think here's the point. With image guidance, you saw me with that hologram and the needle that we're using that has a little guide on it. We know, and this is a lesson I've learned from interventional, you all know this, that interventional radiologists, they can stick a needle almost anywhere, right? But what interventional radiologists don't do or almost never do is stick two or three needles almost anywhere, okay? And so beyond the scope of today's talk, but we can now start to think about, with image guidance, creating a mini surgical field inside. If we can get two or three ports into that ultra minimally invasive area and create a field in there. There are many cameras. I was talking to Dr. Shukla prior to our starting the session today about the idea that there are now super inexpensive sterile small cameras, meaning in the United States, we're using disposable cameras of 3 or 4 millimeters that cost less than $200, and that cost will continue to go down. So you're going to have the opportunity in the operating room to place a small camera in through a small area. And again, beyond the scope of this today, but creating a small surgical field in that area, kind of like what you saw me briefly show. So the answer will be
Great.
yes.
Thank you.
We're going to be able to do this even in the emergency situation.
There's a question from Dr. Saini from Jaipur in India. He's saying, in long-standing obstruction, and if the bowel was loaded with stool, can you still localize the site of intervention?
Increasingly, you can, and at the present time, these cases which I talked about with treating bowel obstructions, you can consider treating them up or downstream, right? If you're lucky. But the key right now is with CT scan and other tools, localizing accurately where the transition or the blockage is, and secondly, where can I access it? Okay, and of course, it's tricky to start saying I'm going to puncture into a dilated, obstructed loop of bowel. That's why in certain cases like that, what we've done is made a cut down. You relieve the obstruction and then you repair surgically. We don't have a, and then I'll just make a comment. It was a quick presentation, but the Nikki device is not FDA approved yet. So we are just about to begin a trial of using this at my institution under IRB. Uh, but the concept I've used in patients, meaning cut down, direct access with puncture, and then repair with using a small, in most cases, a small incision.
Is it helpful, the approach, if you have multiple sites of obstruction? Is that something which can also be attempted to overcome intraluminally?
It can be. It depends on how. how easy you're able to access these areas. In cases where patients have had multiple sites, which is usually from cancer, which we didn't really go into. Everything I was talking about was related to adhesive, but in patients with cancer or theoretically with Crohn's, if you're able to get a guide wire through those areas, you theoretically can try to dilate them. In one case of a patient with an obstruction which was not too far distal, we were actually able to get a guide wire through the obstructions. The patient had a couple hundred cc's, 100 centimeters of gut downstream. We got a guide wire through, we got a catheter through, and then we were able actually to feed that patient downstream of her malignant obstructions that kept her alive uh, nutritionally for about 5 or 6 months. That it was provided significant palliation. So you see, these endoluminal concepts are in evolution, and there are certainly variations on this theme. Yes,
We have a question from Dr. Kunle Oke from Nigeria. And I think in your table where you showed your results, I think you did show that there was a group of patients in whom you had re-intervention was possible using
that's
the
right.
new approach. Is there like an average number of reattempts you had to do? Because he says there's also cost constraints which limit the number of attempts in certain countries where cost becomes a major issue.
Sure. In this series, we repeated it in like 4 or 5 patients a couple twice, right? And I think if it's not successful the second time, or if you had if you did not have a good result, you have to just resolve yourself to the fact I have to operate. I have to figure out another way, right? So you're right. We're not going to keep doing it over and over, but I think the paradigm that has changed in my mind in interventions like this is that it's not like doing like a full laparotomy on the patient. We all shudder at the idea, oh, I'm just going to take them back in another few days and do some, or another few weeks and do. The paradigm shift is you're doing something that has minimal impact on the patient, either endoscopic or percutaneous access. And they're better immediately. They're able to, go home. They're not getting over major abdominal surgery. And as we
So,
define these more and more, that will become more evident.
yes. So clearly, for trainees who are currently mastering laparoscopy or robotic surgery as they currently get trained, and now you're throwing this entirely new field onto them. How should they prepare for a future which is going to impact on them? Because someone who's getting trained today has a career graph of at least 20, 30 years to look forward. And, as you said, robotic may evolve to include these intraluminal approaches as well. But how should they prepare? Because the field is changing so
So,
quickly.
look, all of our preparation, university and education, medical training, school, residency, prepares us for the thought that we have to always continuously upgrade and educate ourselves. The second thing is that take the lessons that we've taken from let's say interventional techniques in vascular. Take these seriously and think about robotic itself. When our colleague from Nigeria asked that question about cost, think about the fact that robotic surgery, it's a great marketing tool, right? But it costs more. And is there anybody on this panel, is there anybody anywhere who's going to say, I have better cancer outcomes as a result of doing robotic surgery? We know that's not true. How do we lower healthcare costs, treat more patients, and have a safer procedure? Okay? Those are the questions that we want to ask. I'm very interested in robotics because robotics in the future, actually, the surgeon, we already know that using robotic tools, we can pass guide wires, tubes, and catheters. Okay? We can be out of the room, not being exposed to radiation if that radiation is being used. Okay? And robotic tools, in my mind, are going to be things like things that you drop into the abdomen. I'm talking about not direct drive type tools.
Sorry, you were saying something.
No, I was talking to my granddaughter. She's asking me because I have to take her swimming in about 15 minutes.
Thank you. I know it's a Saturday.
It's
So,
so wonderful to be here. No, and she's having a good time.
and so in the next decade or 10 to 15 years, if you had to predict one disruptive change in surgery, can you make that prediction?
I I think there will be many, but I think image guidance is where is one of the big things takeaways I think that we all need to consider. Um, for those of you who are coming from middle or lower income countries too, ultrasound, I didn't emphasize it enough, is another a very important tool that we can use that everybody can have at their disposal. Okay. So, so imaging, image guidance, the use of data and artificial intelligence. These are the things that are going to drive things, along with remembering the vascular paradigm, vascular surgery paradigm. And remember this, the GI tract, we also, with percutaneous or through natural orifices, we can look directly inside the lumen of the organs that we're treating, which is an advantage that other organ systems do not have, or the doctors treating those organ systems. So that is why I'm currently looking both at endoscopy in its current form as well as endoscopy through percutaneous accesses.
So there's been interest, a lot of interest in the approach to the appendix. I guess that's going to be a good,
There should be. That's
good
good.
series to do. So there's a question from Dr. Babel. In an appendicular lump, do you think the approach could be helpful? Obviously, people are interested in, perforated appendix, appendicular lump, etc. And I mean, having only heard you, I think it would clearly be of great interest in an appendix which is not perforated or is not surrounded by a lot of inflammation. That would make it clearly a very compelling approach to do. But do you as you move the needle, are you also looking at these different types of clinical scenarios?
Yes, of course. We're doing a procedure right now. It's not just appendiceal, but any, let's say, small mass. Okay. Um, Consider the difference between let's say it's an isolated lymph node after a patient's had a cancer operation that appears in the pelvis or along the aorta or in the mesentery. Consider that we could, instead of sending that patient to interventional radiology to stick a needle in it, that using similar techniques, you just take it out. Okay. That's feasible. Okay. And I'll mention that my colleague in interventional radiology and I had a situation like this, a patient who had an endometrial neuroendocrine tumor or a uterine endometrial tumor. She developed an isolated lymph node in the pelvis. And instead of, he called me, my colleague, and instead of us taking a needle biopsy of this, we just, and imagine how the patient, and it was a malignant neuroendocrine nodule, an isolated one. Imagine also that you as surgeons now, we as surgeons, will have in the near future, I believe, the ability to potentially enter the peritoneal cavity under local with the proper image guidance tools.
Great.
Patients have,
Uh, we have another question, Jeff, from Dr. Eric Tote from Belgium. I think he's trying to ask you, do you think there's a role in an emergent situation for these approaches? Are you ready for prime time, or is it still, something you should not try to do in an emergency or an urgent situation?
I think there definitely will be. Okay. And you can imagine, let's say, the ability, like we've just said, to put a small camera into the abdominal cavity in the emergency room. Yes. We need to explore all these things. This is Ruby, my granddaughter, everybody, by the way.
Hi, Ruby. Great. So, thank you, Jeff. That was, very, very inspiring session. I think we've had many questions, and I'm sure a lot of people will reach out to you. Actually, Dr. Milsom is on the SFS app, so you could chat with him
Yes.
directly on the app. You don't need his email or his mobile number. You could find him there and chat with him. Uh,
And likewise, I mentioned to Dr. Shukla that I will put some of the videos and other interesting scenarios up on the app in the in coming weeks, so that maybe this will stimulate further discussions. I would also say, to my mind today, I'm very interested. So throwing these ideas out, this is what SFS is all about. Let's think about this, folks, ladies and gentlemen. Let's think about how we can change the world of GI surgery in a very positive way with these considerations put forward.
Thank you. Have a great day wherever you are, all of you. Thank you so much for
Yes,
joining.
thank
Thank
you.
you. Have a good day. Bye.
Bye bye.